All right, welcome everybody. This is the first webinar in the 2022 series for the NINDS Clinical Trials Methodology course. As always, we want to thank both NINDS and our program director, Dr. Robin Conwet, for the support of the Institute in making these webinars and our course possible. These webinars are open to everybody, and we've broadly broadcast their schedule to people from the NeuroNext network, StrokeNet, and the Siren network, along with others from other departments. Today, we're going to be talking about how to design meaningful early phase trials. This will be involving a couple different aspects. First, I will be talking a bit about how to select an outcome measure, or what are some of the features of outcome measures. And then Dr. Coffey will talk about some of the potential designs that can be used for early phase trials. So in terms of introductions, I'm Will Moyer. I'm a professor of emergency medicine and neurology here at the University of Michigan. Also joining me is Dr. Chris Coffey, who is a professor of biostatistics at the University of Iowa, and Dr. Lori Gutman, who is professor and chair of neurology at Indiana University, along with Robin Conwet, Dr. Robin Conwet, who is a program director at NINDS. Our other course director, Dr. Roger Lewis, is at Harbor UCLA Medical Center and is unable to join us today. We also have Michelle Minix from the Siren Clinical Coordinating Center, who will be helping with some of the logistics. And not with us today is our sort of course manager, Courtney Miller, but for those who are members of this cohort or were members of the last cohort, you got to know Courtney, and she will be on the future webinars. So with that, I'm going to share my screen, and one of our intentions here is to try to think about some of the trials that you're going to be either designing in the course, or maybe you're designing outside the course if you weren't in the course this year. So we really encourage you to add questions to the Q&A, and that we will work to address those as we go on. You can also certainly put them in the chat. And if you have a complicated question and want to raise your hand, then we can call on you, and you can ask the more complicated question that you don't want to type in. But we really want to use this as an opportunity to try to think through your ideas in the concrete as opposed to the abstract. So we will also have some examples. From a housekeeping perspective, we have about 90 minutes allocated to this webinar. It's longer than our traditional ones. And then at 1:30, anybody is certainly welcome to stay, but we will be doing an overview of what you will be doing if you are one of the members of the 2022 cohort for the CTMC, and going through what the tasks will be in the small groups, and what some of the things you'll be accomplishing over the next 12 weeks will be. Again, that will also be interactive with the opportunity for questions, but we will just try to put a little bit more meat between the sort of words that we have in our syllabus. So with that, I'm going to kick right into our webinar. All right, can everybody see the slides? Very good. All right, move this out of the way. All right, very good. So first, we're going to talk a bit about selecting outcome measures for research. And this is quite important. At some level, if you're doing a later phase trial, this is, this can be, fairly obvious. It's, you're doing a stroke trial, you need to have an outcome measure of the modified Rankine scale for disability. But early in research, you do need to have some outcome measures potentially that can help you decide whether your research ought to be going forward into future phases. So again, as we acknowledged, our course was previously funded under an R25, and it also receives infrastructure funding from Dr. Coffey's NeuroNext Data Coordinating Center grant. We also have received support from the American Academy of Neurology and continue to receive support from them. Oh, yes. And then just as you are looking through the course, looking through this, there is a evaluation form for this. While future CME or future lectures will offer CME, we're in the process of getting our final approval from AAN. So unfortunately for today's, we won't be offering CME, but the future webinars we should be set for. All right, that was pretty bad. Those were my disclosures. I have grant funding from NINDS in terms of relevant disclosures to this course and clinical trials in general. I do some consulting for Berry Consultants, which has various corporate clients in the medical device and pharma worlds. So our website, neurotrials.training, has numerous webinars, recorded lectures, and other materials from our past talks. There's also an outcomes webinar that's very specific to outcomes that was put on by Dr. Scheffner and Adams. There's a link here that I guess none of you would be able to actually specifically click unless I cut and paste this into the chat, which I can potentially do. Or no, I guess since I'm doing this live, I cannot cut and paste that in the chat, but we can put that. That's something that's available on our website. So in terms of what we want to cover in this first part, kind of thinking about the continuum of research activities, thinking about this nomenclature, what's an endpoint versus an outcome. These are sometimes used interchangeably, and whether they're whether this is a process versus an outcome, and then some of the characteristics of outcomes, because these are things that come up as you're designing research studies and in clinical trials in particular. Oops. All right, so if we think about this in terms of the continuum of research activities, people are pretty familiar with efficacy research. So this is a research setting, a classical clinical trial. There's disease-specific, disease-centered endpoints, like, for example, the modified Rankine scale in stroke. Since I work on our stroke team, that is an area where I often give examples. Effectiveness, even though these words sound very similar, is often done in a real healthcare setting with potentially a quasi-experimental design with patient-centered outcomes and potentially outcomes that are economic. Is this something that is saving costs for the healthcare system? So these are different, and sometimes a criticism of efficacy research is it isn't focusing enough on effectiveness. But our philosophy generally, and my philosophy for sure, is efficacy research is quite important because even under ideal circumstances, you need to learn about how well things work and the balance of benefit and risks of treatments. And then moving on to how well it can work in the real world is a step that comes after that. So sometimes sometimes these things do get mixed though, so that people are interested in looking at effectiveness before efficacy has been shown. So translational research is another term that can describe some of the types of research activities that are important. And the idea here is looking at how T2 type translational research, translating the results from clinical studies, often clinical trials, into everyday clinical practice. And this is an effort to implement interventions of proven efficacy and or effectiveness in a non-research and non-experimental setting. You may be still measuring the success of the implementation and the same patient outcomes. For example, I'm one of the multiple PIs of a cluster randomized trial to improve vertigo care in the emergency department by both improving the use of the Epley maneuver in appropriately selected patients, but also getting patients with vestibular neuritis in to do vestibular rehabilitation type exercises. So in both cases, vestibular rehabilitation for unilateral vestibulopathies and the Dix-Hallpike for benign paroxysmal positional vertigo, those are very evidence-based practices, but they don't always translate into the clinic and the emergency department. So we're learning how to best get that as an implementation study by how we can make those be used. But in that study, we are also measuring patients' outcome. How much are we decreasing the burden of dizziness in their lives if they were in our study. And it's an interesting study called Distinct, and we're also measuring whether we can get patients to better care for themselves at home through a patient-specific intervention. So there's an aspect of a patient intervention as well. Then there's pure implementation, so to speak, which is focused on improvement of practice with little or no assessment of patient outcomes. So that there's just some pre-existing assumption that this will be better. This might be reducing unnecessary CAT scan use, and that's, it's a pre-existing assumption. There'll be less radiation, less cost, and if the CAT scans aren't leading to improved health outcomes in general, measuring the patient outcomes is not part of that sort of pure implementation type study. So motivation is important. What types of outcome measures that you're going to pick for the trial that you're going to do or the study that you're going to do should be linked to the type of and the purpose of the research activity that you're going on to. This is the terminology, and this has been, others may describe this slightly differently, but endpoints are a term that often gets thrown around interchangeably with outcomes in clinical research. Clinical trials have endpoints. For example, in an antibiotic trial, do you have sterile blood cultures or sterile respiratory cultures? In an analgesic trial, the pain as measured by the visual analog scale. Health services research often has outcomes, change in the configuration of the healthcare system. Is there changes in copayment, changes to access to specialists, total cost of care? And again, it's not always completely straightforward and not something to be completely torn up about, but it's potential distinction that it can be important. The thing about endpoints and what makes them a little different than outcomes, they're usually disease specific and have some specialized assessment, like the modified Rankine in stroke. Outcomes can be more patient-centered, often multifactorial, and maybe are more like patient-reported outcomes, like quality of life, that kind of cut across a variety of disease states. Outcomes research is the study of the end results of health services that takes patients' experiences, preferences, and values into account. And of course, this is quite important to be doing this sort of research. So this is sort of pointing out that there's maybe a little bit of an artificial dichotomy that I'm presenting you with here, and that an endpoint, you can say that that's a physiologic parameters, clinical parameters, blood pressure at a year. Have you reduced blood pressure? That's, kind of sounds very endpointy. How well somebody is doing is a little bit more outcomey. So there is a spectrum. It's not an absolute dichotomy or binary type situation. So it's just something to think about. Process is not an outcome. So those are things that are healthcare provider centered. Did the physician administer antibiotics within 60 minutes when treating neonates with meningitis? Did a patient get treated with TPA within 30 minutes of arrival to the emergency department? Outcome measures are patient-centered. Did the child have normal school functioning at 5 years of age after an episode of neonatal meningitis? That would be patient-centered outcome measures. So process can be easier to measure, though. Process can be related to an outcome. Process appeals to the physician-centered culture of academic medicine, but to the patient, what a patient cares about is whether they recover from their stroke without disability. If they got treated quickly, but still did not recover their disability, that's not very helpful to that individual patient. So process can impact the outcome. Certainly if stroke patients are not treated quickly, there's less likelihood that people will have a full recovery. So again, time to thrombolytics and stroke, as I was mentioning, can relate to the morbidity of disease. Length of stay in the hospital can correlate with your satisfaction with care. You'd rather be out of the hospital and back in your house. percent of charts documenting antithrombotics within 48 hours, a kind of performance metric in a large population, you're going to reduce your risk of recurrent stroke. So usage measures have some limitations. Like sometimes we worry about whether patients are using the emergency department a lot after some condition, whether they're admitted for heart failure or stroke. And you can reduce emergency department visits by making it harder to get to the emergency department. You can shut down emergency departments. You can hide emergency departments so they're not easy for people to find from the road. In certain cases, there are other opportunity costs that, say like, gosh, this person had a stroke, they had a urinary tract infection after their stroke, but their caregiver works full time and they couldn't make it to a clinic appointment. So by taking that patient after a stroke to the emergency department at 10 p.m., getting the urinary tract infection promptly treated, that might be really less costly to society than letting the urinary tract infection fester and be treated 2 or 3 days later by the primary care doctor, and having to take off work to take your loved one if you're the caregiver of that stroke patient. So it can be complicated. Length of stay also has its tricks, right? Like if it's a disease with high mortality, if people die more quickly, that reduces length of stay. So administrative data often uses length of stay and cost during hospitalization, but there may be very appropriate things going on within the necessary time that aren't well captured in it. So as a sort of length of stay, more length of stay equals bad is not always true, because sometimes a short length of stay means that somebody has died. Quality of care measures are things that are process measures, again, based on assumptions that the associations between process and outcome are important. And sometimes under close scrutiny or new information, these things, while they are sort of put out with the best intentions, don't really hold up to scrutiny or new information as it comes out. When I was an emergency medicine resident, we had a 4-hour rule for antibiotics for pneumonia in terms of admitted patients, but it led to some weird things, right? If you couldn't admit the patient within 4 hours, maybe you were less likely to admit them, right? Say, well, maybe they could use outpatient care, even though perhaps they ought to have been in the hospital. That would have been the safest place for them. So quality of care measures sometimes have somewhat weird assumptions, so they have to be kind of carefully thought about. In terms of some of the characteristics of outcomes, some outcomes are disease specific, some are general, some are close to the beginning of the disease, some are long term, some are physiologic, some are more general. They have some degree of a domain and a range, some have multiple domains. Some are accepted and validated versus newly developed and unvalidated. If you're in our course, the clinical trials methodology course, while your disease might be ripe for having a new outcome measure developed, it is really hard to develop new outcome measures. Harold Adams from the University of Iowa has a great talk about even adding in some additional tweaks to add some more granularity to the NIH stroke scale in terms of motor score. Still, there is a lot of additional work that is involved with that in terms of understanding the meaningfulness of that. But it is extremely important to think about how the outcome is important to patients, parents, the investigator, et cetera. And then reliability and validity are key considerations. Can this outcome be measured in a way that's reproducible across raters? And is it valid? Is it systematically getting the calibration and the answer that it ought to? So in terms of disease-specific type outcomes, meningitis, there would be, a potential for neurologic outcome, whether it's, hearing acuity. Again, that would be perhaps an audiology type exam in terms of the number of decibels that can be discriminated at various points. So that's an outcome that's specific to hearing, but it's specific to a sensory domain a neurologic outcome in one sensory domain. Others may be more general, school performance, activities of daily living, something like the Barthel Index in stroke, where can you go to the bathroom by yourself? Can you do some of these things? How well can you ambulate? And then health-related quality of life, which, based on your health, how rewarding is life in general to you? The scale of proximate versus long-term, if something is happening short after an intervention versus trying to change the trajectory of a disease. And this is something that comes up in our course. We work with some acute conditions and we work with some chronic, potentially progressive conditions. If it's a headache, a pain score is going to change quickly after a rescue medication. However, if you have chronic headaches, then your burden of headache over the course of a month or a year is how things are responding to a preventative medication, for example. So there can be sometimes misleading effects you see in proximate outcomes if there's patients who get lots of I do some cardiac arrest research. People who get lots and lots and lots of epinephrine for their cardiac arrest don't may get more return of spontaneous circulation, but they don't survive the hospital discharge more, and that's perhaps a function of the fact that they have this. If you have a resuscitation that's going longer, there's more opportunity to give epinephrine, and that longer resuscitation was damaging your brain for a longer period of time. So in terms of physiologic versus functional, physiologic measurements are not patient-centered outcomes, even FEV1, but functional or general outcomes, like we talked about before, school functioning, activities of daily living, health-related quality of life, general quality of life. The domain and range, domains are the areas evaluated by the outcome measure: neurologic function, behavior, activities of daily living, costs of care. Range is the extent of the parameter over which there's discriminatory capability. So if you think of standardized intelligence tests, they have a sort of expected variance and standard deviation versus something like the Glasgow outcome scale, which has expected proportions of people in this ordinal scale, going from a perfect outcome to a vegetative outcome. Whether whether an outcome measure is accepted versus newly developed, there are steps. And again, we don't advise trying to develop your new outcome measure for this course, which is, and we will have these slides posted in the CTMC website when we post the webinar. So that's a good question. The typical steps in developing an outcome measure, again, defining the domains, do you need a multi-domain outcome measure, developing a draft instrument, evaluating its reliability and validity, revising the instrument, and establishing population norms and/or further reliability and validity testing. And sometimes there may be a reference outcome, and how well it works in comparison to the reference outcome for that disease can be important. Previously accepted and validated measures should generally be used when they are available. This reduces the time and cost of research and helps ensure comparability of your results with other studies. Sometimes, though, how you use it and when you use it, the timing, for example, we're doing a large study of pediatric cardiac arrest. The accepted time point for the major outcome, the Vineland Adaptive Behavioral Scale, is 1 year. In a prior study, there was a lot of evidence that the 3-month value was highly correlated with the 1-year value. So in our study, we're still keeping the 12-month Vineland as our primary outcome, but we are hoping to gather more data on the 3-month outcome to maybe make it more accepted as really the main outcome in future studies. There are rare cases where you may need to develop and validate a new outcome measure before research can be initiated. Thinking back to the early thrombolytic trials in stroke, a reliable and valid way of quantifying stroke severity was needed because stroke severity was a very important predictor of one's outcome. So that was how the NIH stroke scale was born. So, whose outcome is it? Does it have importance to patients, parents, clinicians, insurers, society? There should be importance to all of these constituencies. Reliability and validity, again, this is a general function of science and research, but what is the relationship between multiple measurements, either between one measurement and a second measurement, reliability, if you're retesting within an individual or an individual at a time point, or between a measurement and an accepted standard, validity. So some of the questions as you're designing your research are what population you're looking at, what's the setting, whether you're needing sensitivity or specificity, bias, precision. What is the study trying to learn about with respect to that outcome? So when you're doing a new study and you're thinking about your outcome measure, you have to think, was your outcome measure developed and tested in a patient population that's similar to how it is now being used? Are the age distribution similar? Is the distribution of severity of illness or level of disability similar in the two populations? And I think an example of this would be, while the modified Rankine in stroke was mostly developed in ischemic stroke, there are a lot of similarities with patients that have spontaneous non-traumatic intracerebral hemorrhage. So that has a similar age distribution, often a similar severity of illness and similar level of disability. So in those cases, it's a relatively easy lift to consider using something like the MRS in an ICH study. Was the study, this is something that can be very important sometimes if there's a lot of sort of social context to an outcome measure. Was it developed and tested in a similar setting? And are the people administering the outcome similar to those who had tested it? Does the outcome, and this is sensitivity and specificity, you might have thought, oh, I'm going to be talking about diagnostic accuracy, but here I'm talking about how your outcome measure is. Is it sensitive? Is it going to classify people into, if it's a dichotomous outcome of disabled versus non-disabled, are we really good at picking that up? Does the outcome measure have sensitivity in that space? And does the outcome measure have adequate specificity? Is it falsely accusing some patients of having more disability than they should? Is the outcome measure free from significant bias? Like, is it something that is very effort dependent? Like, I was measuring my ability to do a picture sorting task, and because I hadn't had my morning coffee, I wasn't really paying it, and it was a loud room. I was able to bias my result and do rather poorly on that task. So trying to eliminate anything that's going to systematically change, either make better or make worse, the response on that outcome measure is important. Precision or reliability, we talked about a little bit. Does it have sufficient precision, and that when it's measured, you're going to get in a systematic way, you're going to get similar results that are sort of clustered around the desired truth for that, and or does it have intrinsic reliability? And again, this is something that's important for major outcomes in clinical trials. If two different people are doing it, are they going to come to the same conclusion? And that's for if you think of the NIH stroke scale, the reliability for those who do stroke, and sorry if you don't, but like the reliability of an NIH stroke scale, a motor arm score of 4, where there really has to be no movement, that's something that's a little easier to classify than whether the facial droop is very severe versus less severe. So arm doesn't move at all, going to have a little bit higher inter-rater reliability, and then some of the other. So this can vary within different domains in an outcome measure. So does it measure a characteristic that you really want to measure, the validity? Is there an appropriate standard against which validity has been tested? If there's no appropriate standard, is there a way to look at the internal validity? And this is, again, It's not something that we recommend, but there are ways to kind of create the new outcome measure. But we generally, for the types of research that people are doing in the clinical trials space, we typically are avoiding those things. So in terms of this sort of initial idea of what is it that you're going to measure, right? This is an important aspect of doing science, is you're measuring something, and then as we are focused on clinical trials, delivering some change in the situation, an intervention where people are being exposed to different conditions, usually through randomization, and are those outcomes different across those things? So it's important to have really proper endpoints and outcome measures. You have to understand how well your outcome measure works, how much noise there is in the outcome measure. Again, if we think about sample size, if there's what's the natural course of the reduction in your ALS-FRS over time. That's something that if you're designing a trial in ALS, you have to have a sense as to what one might expect in a population of people, knowing that but how much variability is there in that across that population? That's a question that clinicians need to work on in order to have good conversations with their statisticians to help design trials that can separate the signal from the noise. So it's important to know your outcome measure well as a clinician designing clinical trials, how it performs, what the context of where that outcome measure came from, and what you might expect to see in the general population prior to an intervention and how that outcome measure is going to look. There are a lot of different statistics, epidemiology, and service research that can help you better understand the rationale and performance of that outcome measure. And I think with that, I have some additional slides if necessary, if we have specific questions in those areas. But at this point, I will open it up for questions if anybody has any, or for the other course directors, if there was anything else you wanted to add on this idea of outcomes before we hand on to the next part for Chris. All right. So I'm going to briefly stop sharing here. And I'm going to pull up Chris's slides.
I can pull them up. I've got them open if I can show.
Perfect. You go for it.
All right. So Will covered more endpoints. I'm going to talk more about the broader design of what are you trying to do with an early phase clinical trial, which is where most of the projects for the course would almost by definition need to be in. And I think part of this is a lot of, if you take a course or a short course or a webinar in clinical trials, many of them will be more phase 3 focus, or more into the confirmatory stage. But designing early phase, I think, are in some cases more difficult because you're more limited in size and scope and access to the number of participants, and you're not trying to show efficacy, but you're trying to get some evidence of efficacy or of safety to kind of inform whether it should move forward. You're trying to get a sense of dose. You're trying to get a sense of what are the best endpoints. And so I think there are a lot of challenges to doing that, but one of the main foundations that I think you have to keep coming back to is that any clinical trial, regardless of whether it's phase 1, phase 2, phase 3, should be set up to have at least one, if not more than one, primary objectives. And that typically would correspond to a question that you're set out to address in the clinical trial. And regardless of whether it's a large confirmatory trial, a very small phase 2 trial, there should be some question that the trial is addressing And one of the things that in NIH-funded clinical trial applications, we typically don't do as well as an industry trial would do is look at where this trial fits into the broader scope of a program of research for looking at this. So in an industry setting, if you're conducting a phase 2 trial, it's pretty clear where that fits into the goals of where things would go and what from the phase 2 trial would suggest you should keep that program path moving forward and what might suggest putting a halt to the path because it doesn't look that promising. Those types of concepts, while not necessarily needing to be addressed in as much scrutiny in an NIH grant proposal, should be part of the thinking in terms of doing this when putting the design together. And you would want to know what is the question, and then your sample size calculation should be put in place so that it can justify that you have the ability to answer the question. If you can answer the question, you have a positive clinical trial. And a positive clinical trial, as we will probably repeat multiple times throughout the course and in small groups for those of you who are going through it this year, doesn't necessarily mean that you show the drug or the intervention is statistically significant and effective. A positive trial is one that answers the question of interest. So if a drug works, you're able to show that it works. If a drug doesn't work, then you show that it doesn't work and you cease that line of research. By definition, a negative trial from our perspective as the course leaders would be one that you put a lot of time and resources in and it doesn't answer the question of interest because it wasn't set up properly. There was no way it could fail. It didn't have appropriate power. So even if the drug didn't work, there's no way that you could show that it works. Or even if the drug worked, you're not able to show it works because you didn't have sufficient power. So one question I think you often need to ask yourself as you're fleshing out a design is, can this trial fail? If the trial can't fail, then it's not a good design because there should be some threshold at which you see promise that tells you to move forward. If you can't meet that, then perhaps that suggests that you don't have a promising line of research moving. Part of this is making sure that you flesh out the question of interest, in terms of detail of exactly what you want to look at. Some of this gets to the choice of outcome in the way that Will just described. But if you come in and you say, I want to show is drug A better than placebo, that's a pretty broad, open statement that could mean many different things. And so in designing a trial, you often have to be much more specific. So in what population, we're looking at drug A at what dose, is it more efficacious in reducing what over what period of time compared to placebo? So that level of specificity is part of the design process. And as the statistician, a lot of times when we sit down initially with someone who's fleshing out a clinical trial, it really is almost like talking two different languages. There's the clinical language and the statistical language. And developing the question is very much trying to put those together and come up with a question that addresses clinically what you want to look at, that is stated in a form that a statistical design can be developed that can answer that question. And so a lot of the upfront conversations will take place in trying to get clarity on exactly what is the question of interest. Once you have the question, then each objective should link to a primary endpoint. And those endpoints, the properties have to do a lot with what Will talked about. I won't reiterate the necessary properties here because Will kind of covered those, but you want to make sure that you have good justification for the endpoint that you want to choose. There was a question earlier while Will was presenting the answer, like, could you have like a first phase in a grant application to look at your endpoints? And that typically wouldn't, in my opinion, wouldn't fly in a clinical trial application. You would have to have pretty good justification for your endpoint that would need to be part of the application. So that would have to be done kind of outside so that you have a sense of what the appropriate endpoint is. Some examples of endpoints for neurological disease, and this is kind of how you take the concept and develop it into something that can be measured and assessed over a trial. So for pain intensity, then your outcome might be decreased pain intensity, but you have to define what that means. So change in pain intensity as measured by a 10-centimeter visual analog scale over 90 days. Stroke prevention, decrease in stroke rate. Again, what does that mean? Reduction in proportion of patients with stroke over a 3-year period and so forth. So you have to kind of take this broad concept. I think that my drug would decrease the rate of stroke. What does that mean? How are you going to measure it? What's the time frame you're going to measure it over the course of the trial becomes very important. And in the early stages of designing a clinical trial is something that you will likely spend a lot of time on. Now, secondary objectives can be important. I will tell you my personal opinion is people shove way too many secondary objectives into phase 2 clinical trials that are dramatically underpowered and are really ways to just kind of cover all your bases and make sure that you see something. And as any of you who had an introductory statistics class know, with the multiple comparisons issue, if we ask enough questions, we're going to find something somewhere. And so if you put in 25, 30 secondary objectives, you may find something at the end of the study. It may have nothing to do with reality. It could just be a type 1 error. And so you want to be very parsimonious in terms of choosing secondary objectives, and choosing secondary objectives that might be relevant to getting you where you want to go in the next step. So for instance, if you have a good biomarker, maybe your early phase design is powered to show differences in a biomarker, you have a clinical endpoint that you know you're underpowered for in the earlier phase trial, but would be a likely candidate for an endpoint in your later phase trial, you may collect that clinical endpoint as a secondary objective, knowing that you're underpowered, but you want to kind of get a sense if you have success on your primary biomarker endpoint, do you see a trend with respect to the secondary endpoint, and get information that would help you plan that additional study. If you throw 10 or 12 other things in there, it's probably just going to water down things, and it's going to complicate things to a great extent. The other argument for not throwing in too many secondary objectives is with the regulations currently with clinicaltrials.gov, if you have to register your trial on clinicaltrials.gov, you are also required at the end of the study to post results for every primary and secondary objective. So the more secondary objectives you put into your protocol, the more things you're going to be legally required to report results for at the end. So if you have things that you're not clear on exactly how you're going to look at them, it's probably not a secondary objective. If you want to include them in the protocol, those would be things that would fit more as what we would call exploratory objectives, which have a little less stringency in terms of reporting and how you would need to address those in a formal statistical analysis plan. All right, so just to talk about the types of trials, and I think some of this may be review for many of you, but for those who this may be a new concept, it's important to put in context. It generally starts with what we call phase 1 clinical trials, which would be the first trials done after preclinical investigations have concluded. And this would generally be for a new drug, this would be kind of the first time it's tested in humans. If you're looking at something that's been studied in a different disease area, then perhaps this might be something that has been assessed maybe well in that disease area, but has never been used in your disease area of interest, and you need to assess the safety there. The main goal in phase 1 is almost strictly safety. You're really looking for, in many cases, these are set up to look for what we term the maximum tolerated dose, where it's based on a general assumption that is true most of the time, but not always, that as the dose increases, you will get more toxicity, but you will also have a better chance of seeing efficacy. And so with these early phase studies, what we're typically looking for is how high can we go in the dosing range before we get an unacceptable risk of toxicity, which should then kind of cast the upper kind of limit in dose and what we could consider in future studies. We may not go that high in other studies. We might have reasons to look lower, but it at least gives us a sense of what is the meaningful dose range that we could explore in future studies. Assuming that you come up with a meaningful dose or doses in phase 1, then you would typically move to phase 2 clinical trials. Phase 2 clinical trials, in many ways, I think are the hardest to design, in the sense that what you're trying to do is to look at further safety information, expand on the information at the doses that you've chosen to move forward. At the same time, you're often looking at what we would call proof of concept. You're not testing efficacy, you're not powered to test efficacy, but you have some threshold of benefit that needs to be met that would justify moving forward into doing a larger confirmatory phase 3 clinical trial. And so setting up the criteria, what is the question, how can you set up thresholds, how could it fail, how could it succeed, may take a lot of trial and error with respect to many phase 2 clinical trials to find exactly how to best state that in a way that meets the principles that we talked about just a few minutes ago. What you're really wanting to do here is to screen out ineffective treatments. So one of the biggest challenges with phase 2 clinical trials historically has been that many times they would be done with what you would typically want to do for the phase 3 trial, but much smaller. And so that would kind of be what we would refer to as an underpowered phase 3 study. And perhaps because it's underpowered, you can't tell if it's promising or not. In some ways, that meets the criteria we mentioned before, that it really can't fail. And you're almost always with high probability going to go forward if you do that type of study, because there's nothing you're going to see that would convince you that the drug or the intervention doesn't work if you thought that it did and that was your rationale for doing the study. which most likely, if you're the investigator doing the study, you have a pretty solid reason to believe that it does work. What tends to happen in that case is if you're going to move forward regardless, then you do the phase 2, you get to phase 3, and then the phase 3 may fail after spending a lot of time, money, and resources in phase 3. This is again where NIH-funded trials and industry-funded trials may differ in philosophy. If you're a company and it's your investment that that you're determining what to move forward with, if you want to be more or less stringent in your phase 2 study, that's kind of up to the company and how risk averse or much risk that the company wants to take on in terms of the chances of a phase 3 study failing. In an NIH-funded environment, the studies are being funded essentially by tax dollars, right? It's our money that is paying for the studies. And so having phase 2 studies that aren't designed well, that lead to phase 3 trials that fail, is going to be really costly and a poor use of taxpayer funds. And so that again is why we often want to have good criteria and lead to, in many cases, currently what we often look for in phase 2 trials is what should be the go and the no-go criteria that would determine whether the trial should either proceed to a phase 3 trial or should halt and not proceed further. There is a question about what's the difference between phase 2A and phase 2B trials. I will say that's kind of an arbitrary thing that probably means something different to different people. If I had to put a definition, I would say a phase 2A trial may be a phase 2 trial that may not directly go to a phase 3. It might need a subsequent phase 2 trial to be conducted. Whereas if you're in what would be considered more phase 2B, your next step is almost always going to be a phase 3. That being said, I think if you polled 100 different clinical trialists, you might get at least 75 different answers for what a phase 2A and a phase 2B trial is. In general, I think even though historically there's this phase 1, phase 2, phase 3 nomenclature, if you think about it more broadly, really, and some of the guidance documents for FDA have even moved in this direction, there's really 2 broad phases. There's the confirmatory phase, which really fits into what we would typically call the phase 3 space. But there's also then what we would call a learning phase, which a learning phase would combine phase 1, phase 2A, phase 2B. And the steps that you would need to take to move through the learning phase may vary substantially depending upon the agent and the disease that you're studying. You may only need 1 study in the learning phase. You may need multiple studies in the learning phase. And that's maybe a slightly better nomenclature because it's not always that you have 1 phase 1, 1 phase 2. You may have multiple in different types. And depending on what you find, you may have to take a step sideways or backwards and recalibrate to determine how to move forward as well. All right, so one of the things, without the justification of go, no-go criteria ahead of time, so what we hope to do with this is to specify the criteria ahead of time, set up the sample size with pre-specified rules and know what the operating characteristics or the statistical properties of the study are before we launch. If you haven't specified go, no-go criteria, then it becomes really challenging to make a determination at the end when you're seeing the results and it's driving what you want to do. And if there's one thing that clinical investigators are really good at, it is explaining why a surprisingly significant finding makes sense and explaining why something we expected would be statistically significant but did not show to be statistically significant may have been due to problems in the design. We are biased by what we think. And so you could take results from a clinical trial, you could put them in front of 2 investigators, and if one investigator had a preconceived notion that the intervention works, they could see that data as very promising and supportive of that assumption that the treatment works. Whereas another investigator who feels equally strongly that the treatment does not work could look at the same data and be just as convinced that it casts doubts on whether the treatment works. And so it's important to kind of have your criteria specified in advance to remove this level of subjectivity at the end. Also, the second point with the go criteria, you want to have a go criteria on as narrow a set of important procedures as you can, because if you had multiple endpoints and you said, for instance, I'm going to look at 10 endpoints and I'm going to go forward to a phase 3 trial if any of those endpoints meet statistical significance at the 0.05 level. it's fairly easy to do simulations to show that even if your drug doesn't work, you would have high probability of meeting that go criterion going forward. And so when you're assessing the properties, you want to make sure in situations where you would not want to go forward, that you're not incorrectly going to meet your go criteria. And all of this should be assessed as part of the study design and planning phase. Now, there are many different types of phase 2 clinical trial designs. We can talk about some of these more. I'm not going to go in depth into these in the presentation. If people have questions about specific ones, we could talk about, or as some of you get more involved in your protocol development through the course, you may find yourself wanting to know more information about one or more of these. And this is not an all-encompassing list. There are many different types and many different options besides this, but they kind of fall into two different categories. There are either designs that use different endpoints than the phase 3 endpoint. These would be things like a safety tolerability design, where perhaps in a very early phase, you want to see, do you meet some level of safety, or do you meet some level of tolerability? Like tolerability would be defined perhaps by getting to the end of the planned follow-up on the assigned dose, right? So if people can't tolerate the drug, if the drug works or doesn't work, it's going to be hard to make a case that it's beneficial if half to 2/3 of the people you assign can't take it. Safety would be, are you trying to show some sufficient level of safety? We can never show in any clinical trial that the drug is safe. So our objective should never be, we want to show the drug is safe. All we can do is rule out various levels of safety. And so part of a safety design would be ruling out, right? Basically the drug is not extremely unsafe. It meets sufficient level of safety to move forward. Another example of a study that uses a different endpoint would be a surrogate endpoint design. This would be something like I mentioned before, where you might be interested in using a biomarker for the phase 2 study, different from the clinical endpoint that you would use for the phase 3 study. There is a lot of interest in those types of designs, and in all honesty, they would be used much more if we only had better biomarkers. So that's a whole different question, that in many disease areas, there is a dramatic need for better biomarkers. There are other types of designs that use the phase 3 endpoints, but do it in ways that can meet go/no go criteria, not in the same way that you would need to show efficacy for a phase 3 trial. These include various 2-stage designs. These have been introduced a lot in oncology, but have been moved into other fields, including neurology. Predictive probability designs based on Bayesian methods, where you look at, given what we have under some assumed effect and specified design for a phase 3 trial, what is the probability of having a positive or negative study, and that might determine whether to go forward or not. N of 1 designs, selection designs, and futility designs. These are all designs that can use the types of phase 3 endpoints, but they don't look like a phase 3 trial. So they don't meet that concern of being an underpowered phase 3 trial. They have different criteria and different specifications for success. There are a couple things in the chat, so I'm trying to look. Does this 2-stage design include an a priori change in primary endpoints? It does. The 2-stage designs that we talk about here typically would not. Like for the ones used in oncology are just based on 2 different stages and looking at success on the same endpoint. There are 2-stage adaptive designs that can involve a change in endpoint or cannot involve a change in endpoint. One that we are not really getting into today because it's not really relevant for the course, the protocols done in the course, but you could do an adaptive design. It's one of the things mentioned would be an adaptive phase 2/3 design, where instead of doing a phase 2 with a surrogate endpoint, and then if you meet success doing a completely separate phase 3 clinical trial with a clinical endpoint, you could set up a single trial where it's a seamless phase 2/3 trial where the phase 2 decision would be based on the surrogate endpoint. And if you meet that criteria, you continue on, and then you would do the final analysis based on the clinical endpoint. So that is an option, but it's probably not something that would be relevant for the types of protocols that would be developed for this course. Just kind of expanding on some of the things he said, some common errors in drug development, and these are things that come up repeatedly in fleshing out the protocols for the course as well. Poorly designed, optimistically interpreted proof of concept studies. This really gets to the need to ask yourself, can my study fail? If your study can't fail, then you probably need to go back to the drawing board and think about coming up with a design that can better differentiate a promising and a non-promising intervention. Insufficient exploration of dose, regimen, and route. There's often a rush to move into later phases. But if you move too quickly without having adequately explored, for instance, the dose range, then you might fail in the phase 3 trial, say, because you have the wrong dose. You're not at the right point where you would need to be. And so taking time to carefully explore the options for doses, the regimens, the routes of administration can be important. And then also, I mean, another common area is moving forward, getting to phase 3 without adequate early phase data. If you've not done adequately designed and vetted phase 2 trials to get to phase 3, you're likely to fail in phase 3. And that would be costly. And if you were to submit a proposal for a phase 3 clinical trial, from my experience on NIH study sections, if you don't have strong phase 1, phase 2, and preclinical data to support that phase 3 clinical trial, it's most likely not going to be reviewed very well. So just to kind of summarize, there are 3 basic requirements that would be true for any clinical trial: phase 3, phase 1, phase 2. That's your trial should examine an important research question. Your trial should be based on a high level of scientific rigor, and it should be based on ethical considerations that assure that the risks to subjects are minimized. Now, in a phase 2 trial or a phase 1 trial or any other type of early phase trial, because of the limitations on the scope of what you can do, that can be a bit of a challenge. But it is important to still keep these in mind as you are fleshing out the design of your study, because their importance is equal in the early phase setting as it is in the late phase setting. And so in many cases, the importance of study planning and having a team that can help you with planning the study becomes extremely important for these early phase studies. And that really gets to what one of the goals of the course is to help those of you who want to get into clinical trials research and have a good idea, is to have an avenue where you can work with leaders that have done this before and flesh out the protocol in ways that address many of the things we talked about here. So I'll pause there and we can take questions, or we can move to the next step.
I see there is one question about the 2-stage design.
Yeah, I addressed that one, I think.
Yeah, I mean, I think I've, that's one of the sort of tricks I think about some of the single arm futility designs and these 2-stage designs, is you have to have a really deep understanding of what the expected proportion of quote unquote response is. And I think, a lot of times, because there can be differences in the population, if you enroll a bunch of, I'll use another stroke example. If you think you're going to enroll a bunch of stroke patients who have a stroke scale of 10, you can have a decent idea as to what you think their expected distribution of Rankines are going to be. But then if your study all of a sudden enrolls people who have lower stroke scales because of some other people being shunted off for other treatments, you're sort of, if you're kind of using some objective proportion as your sort of go no go criteria, it can be a problem. I think let's see, I don't see anything else in the Q&A. I think what we were hoping is if the people in the audience had trial designs that they were or trial areas or problems they were sort of struggling with. I think a key takeaway, and that was a great talk, Chris, is it's these learn phase trials, these middle phase trials are hard because it's not as clear how to make the go no go criteria, right? Like where do you need more information, and when you sample and you get that information, how do you use that information to go forward? I do have a sort of a worked example that's less that's a little more concrete, that I can start to pull up while people think of questions. But now that I think we've promoted Dr. Gutman. Dr. Gutman, did you have any reflections or other things? No reflections. Okay, perfect. And yeah, so I think with that, let me just give me a second. I will pull up this example. You will be all shocked to learn that it's a exploratory phase stroke example. All right, so you all can see this now.
Yeah.
Ooh, and I forgot we have our new logo that I hadn't put onto these slides. We'll have to make sure we get that going on our next set. All right, so the context of let's say like I'm trying to design an exploratory phase acute stroke trial. If you look in general for drug trials, and this isn't limited to stroke in terms of the statistic, a large proportion failed to have a positive phase 3 trial. And depending on the disease area, if you study Alzheimer's disease, that proportion of quote unquote defining failure is not showing a positive treatment effect in phase 3 is even higher. These are some of the rates across different therapeutic areas, and sort of predictors of whether or not your drug or agent is going to lead to FDA approval. Again, knowing that in the neurologic space, it's a little bit lower. Infectious disease is a little bit higher. I think some of that has to do with differences in outcomes like we talked about. Preventing an infectious disease or promoting the survival of it can be a little less complicated in certain respects, although very important than perhaps preventing stroke disability. So these are just some of the, but overall, like a bit less than half the time, drugs are getting on to approval. The approaches to phase 2, Chris really covered this. Are you going to use a phase 3 endpoint carefully? Not doing an underpowered efficacy study. Can you use a surrogate? Can you do single arm futility, which you talked about, if you really know the outcome rate? Like, if I'm sure that my group of stroke patients, 35% of them are going to have a modified Rankine of 0 or 1, then doing a study where I see if I'm better than 35% with my new treatment, or within a range of uncertainty around 35% can be a strategy. But again, particularly for stroke, I think if your population changes a little, that expected outcome rate also changes a lot. And you can do multiple doses. If multiple doses are all not changing things, then that can you can get 2 potential outputs there. If all of the doses don't have activity, then you are quite sure that perhaps the drug doesn't have activity at all. And potentially the phase 2 trial, if you do have multiple doses, can help answer a question as to the 1 or 2 doses to bring forward to the phase 3 trial. So it's stroke, we talk about the modified Rankine scale. It's an ordinal non-interval scale, and this is something that's always the trick. It ranges from 0 to 6 with no disability or symptoms through dead. But the gradations, the difference between going from 0 to 1 is a little bit more potentially subjective, having some symptoms. Do you have headaches after your stroke? Do you have a sensory problem after your stroke? Whereas going from 1 to 2, are you able to carry out all of your prior activities? So that's a big step. It may be a little different from that 0 to 1 step and 1 to 2, and then going from 3 to 4, potentially being unable to get around. Those are sort of major changes and major steps that aren't all equal in terms of their importance. So this is something that comes up a lot for people. We have to design a small trial that gives us some go no go signal for us as to whether we should do a follow-up trial. This is when you're submitting large scale grants. You want preliminary data that makes the review panel and the funding agency excited about doing your thing. Consider TPA for stroke as an example. If we say truth is 39% of people who get TPA and 26% of people with placebo get better, get to an MRS of 0 to 1 if they have inclusion criteria similar to the NINDS TPA study. That's an assumption, right? We're dealing with patients who are enrolled in the early 1990s at this point in time, so stroke care is different. So that's one of those things about using these historical rates that can be somewhat fraught, is that care progresses underneath some of the best clinical trials data that you have. But one approach to phase 2 is there some treatment effect? What's the probability that your new treatment versus TPA, or I'm sorry, TPA versus control is 5% better than control, or the probability that TPA is 10% better than control? And when you're designing your phase 3 trial, you can use statistics to learn about these probabilities. You say if you had enrolled 200 patients, you would get some estimated probabilities that TPA is 5% better, 10% better. But one thing that you should definitely not do, particularly in trials that are funded by NINDS, and say that, I observed in my trial that TPA was 8% better than control. So I'm going to go to phase 3 and I'm going to use 8% to define my sample size, because there's noise in that sample size. So using that point estimate can be a problem. But you can look at if you're trying to define go, no go criteria, if you think you really need to be 10% better than control to make it worth the hassles of doing the treatment, then you can set up your trial to identify that degree of difference between the groups, should it exist, and give you some probability that it's there. So one option is to use this idea of predicted probability of phase 3 success. If you're doing a future 2-arm trial, 600 patients, or a future 2-arm trial with 1,500 patients, and that would be your way of approaching a phase 2 study. So you could consider sample sizes from 50 to 300 and have you need to have some sort of decision threshold, whether there's a 50% probability of a greater than 5% treatment effect that would be confirmed in the phase 3 trial. And you can use numerical simulation to kind of determine at each of those sample sizes, how often does your study tell you should go when there really is promise, but then how often does it tell you to go to phase 3 when there isn't promise or a null result? And you can think of this as to whether there's this large 13% difference in effects, whether there's a modest effect, but then also the null effect. So you apply this mathematically. You do these sort of biased coin flips of many patients, and you look at, in that design, if I enroll 50 patients and there is a large effect, that's the 39% versus 26%. If that is the truth, about 71% of the time, if you use 50 patients and you use the math, a greater than 50% chance of a 5% or greater treatment effect. 71% of the time you move on to the next phase. So that's good, but we as stroke doctors would be very sad if we decided not to go on to phase 3 for TPA when it truly was that promising. So that you can see that then if you increase that sample size of that early phase trial to 225, if there really is that large effect, then you have a 91% chance of actually identifying it. Interestingly, though, if there's no difference at all, you still have about a 20% chance of going to that phase 3 trial, just because with your estimate of whether or not you're 5% better is still pretty noisy with only 225 patients or so. So this is one possible approach to setting go, no go criteria in the face of a randomized phase 3 trial, to really set these sort of objective, we're going to do the next study if we see this, and this is how well we can detect these things. And I think this is a potentially interesting and powerful way to look at using a smaller trial to inform whether a later trial should be done. And again, this is just the last slide presented a little bit graphically. And again, this is I think the same thing. So again, what's the right sample size? Again, it depends on your resources and how long it might take to enroll people. Do you have enough of a sample size to address imbalance across groups? Is the type 1 error acceptable? Here, you're not approving a treatment. You're basically approving an investment in a larger study and trying to increase the chances that larger study is positive by screening out neutral or null treatments. Is there other information that could be used as a surrogate or helpful? Was reperfusion successful? So those are other things to consider in a design like that. And I think with that, I will. I think we've started to get some questions in the chat.
Yeah,
so
Will, there are a lot of different questions. So one one that came in earlier was about thinking about design of phase 2 trials in implementation studies when you're testing a process, and whether you or Chris would like to expand on the utility of, or whether this is beyond the scope of this discussion today about implementation studies.
I think, Chris, I know that we both have some experience in implementation studies. I would agree that the sort of drug-based paradigm of phase 2, phase 3 is a little bit like doesn't fit that it's a square hole in the circular pig. I think in the broader, more general sense of looking at a study as, is it a learn phase study? Do you need to learn something to determine whether you need to do, how to do the next study, or is it a confirmatory phase study? Is the ultimate goal, is this an implementation study that is, I am learning about a process to get people to care for dizziness patients in the emergency room in this way. And the real goal is, if I learn how to implement this, it's going to just sort of go out across the country and every hospital system should start doing this. Is that the sort of output of my sort of confirmatory phase implementation study? Or is it something that's an earlier type question? Do I need to learn what components of a implementation type study are most effective in terms of leading to whether it's behavior change or change in patient-oriented outcomes? So I think in terms of the implementation study, it may be a little too hard to completely discuss it here, but I think it depends on what is the implementation study designing to change. Is it having a goal of changing patients' outcomes positively, or is it delivering some evidence-based intervention to more patients? And is it something that ought to change practice relatively universally, or is it learning how to really determine whether your implementation paradigm can effectively change behavior and lead to that? I don't know, Chris, if you had anything you wanted to add on that one.
I mean, the only thing I would add is, if you're talking about an implementation design in a clinical trial context, you'd have to be able to clearly define your implementation. You can't tweak and assess an implementation in the same study. So if you're still reworking what your implementation is, then you're not doing a confirmatory clinical trial, regardless of how you try to cast it. We run into the same problem with, if you're trying to do some type of brain stimulation, right? And there's no defined definition of how you're going to tweak it each way. It's the same thing. If you don't have an intervention defined, it'd be just like, we know we're going to give this drug to people, but we'll figure out the doses to each person as we go along. And that's not a confirmatory drug trial. It would be the same thing with the other types of intervention. So, and it may be that you still need to learn about your intervention, just like you may need to learn about dosing in the drug before you do the confirmatory study, but you have to kind of separate those two.
Yeah, I mean, you could almost think of it like through the sort of drug trial example. If you do some reading, if you're not familiar with this idea of an N of 1 design, an N of 1 design seems kind of interesting. It's like you're trying different things within an individual over time. Makes the most sense within the perspective of a chronic condition, maybe a painful condition, or something like that, where there's something that can alter over time within an individual with some washouts. You can kind of test various different things within the individual to learn what works the best. And I think on that sort of continuum, sometimes the implementation studies are still in that phase where there may not be a general implementation strategy that's going to work across all health systems. For example, if it's a health system focused implementation study, and you have to kind of learn and turn the cranks within each institution. The idea of designing the trial is figuring out the package, which is here's how we tailor that treatment, the dose of that treatment, so to speak, at those hospitals. But you have to be able to write out in advance what it is that you're going to do, the full package, before you try to test that and learn about its treatment effect. I think the next question.
Yeah, one of the, I don't know what you, one of the other, Chris answered a couple of questions within the Q&A already, but there's a question of disadvantages or of using multiple doses when designing a phase 2 study. Another one is it bad to have more than one treatment arm? In other words, 2 doses in a phase 2 study? Does it decrease the power substantially? Subtle disadvantages aside from that?
I can answer the multiple doses maybe first. I mean,
okay.
It depends on what your, it depends on what your rationale is for having multiple doses. If you're going to compare each dose to a control or placebo, then you are going to lose power versus if you had a single dose. That's clear. But you may also be interested in, is there some type of dose response that would inform what you would need to do? And you may have, it'd be a different sample size needed to look at a dose response versus to do comparison. So it's not just how many are you putting in, it's really thinking carefully of what your objective in question is. Like a good example, we mentioned when I talked about phase 1 designs, we typically think higher doses or more toxicity and more efficacy. But there are examples of drugs where that is true for the most part, but you might reach an area where you plateau for efficacy. And so going to the highest dose for safety, you might be able to go to a lower dose and get less risk with the same level of efficacy. And those are the type things you would know if you explore, the fuller dose range. So one of the bigger caveats, which again goes into more of the industry way of thinking, where you're thinking of this as a program, is that if you spend longer and do more detailed studies in early phase, you will have a greater chance of success in phase 3 if you go to phase 3, because if your drug is going to fail, you will fail more likely if you've vetted it more thoroughly. That's sometimes hard to swallow when you're writing a grant, trying to get funding to do a study in an NIH environment. But if you at least think of that concept in the back of your mind as you're trying to determine what to do, that is one that can help you in terms of designing a study.
I guess the other thing I would just sort of add on to the idea of dose response is, if somebody asks a question of like, should you choose 2 doses in your phase 2 or 1? And I think if you can, 2 is a little tough, right? Like, because if you want to know about a dose response, you're fitting a line, it's like 0, 1, 2. There's so many different ways that line can be. So potentially you have to think but if you were, and again, I'm not going to say that you should always study 10 doses or 4 doses, but depending on the clinical question and the sample size that you have available, if looking at where a plateau might be in terms of dose is important, there are methods that can help you learn about where that plateau is and sort of drill those patients into places where they can be helpful. Now, if you've established, but sometimes there's biologic constraints, right? How much of this drug is going to stick to receptors. So unless there's a serious sort of toxicity question, and then you want to have that lower dose as a backup in the event that you more precisely learn about toxicity, then there could be a good reason to have both of those doses. So I think those are, I think it depends, but I think if somebody is, it's something you have to work out as a clinician with your biostats partners and colleagues a lot, to think about where is it that you want to, sort of, where do you have uncertainty and where do you want to spend it? And I do think, though, that we ought to, when we're thinking about drugs, I think it's time well spent to be more intentional and spend more patience on finding the right dose, because I think sometimes we don't have that very well estimated, and we sort of get lucky with doses, and that's I think that's Chris's point with respect to industry. if they're going to spend a bit more time searching through 5 potential doses, they're going to understand more about dose response.
Lori, what was the second question? I forgot what your second one you mentioned a while back was before we answered the 2 dose question.
I think it was, they were tied together.
Okay.
We have another question about, how do you, developing effect size? Are there ways to decrease guesstimation for effect size?
Chris, I can go first. So I think one way is if you're using an outcome measure that has a really established relationship to a disease. Like, I know that if in a population of people, I reduce their blood pressure 4 millimeters of mercury, I can reduce stroke this amount. That's one example of an effect size, but blood pressure as a single parameter is not something that we use. One of the problems is that a lot of times we have binary or binary-ish type outcomes, like alive or dead, disabled or non-disabled. And an effect size, the effect size for a binary outcome is sort of related to where are you on the probability space? Are you around 50%? Going from 45 to 50% is harder than going from 5% to 10%, right? There you've doubled your outcome as opposed to just sort of moved around. You're still around that 50% spot. So that changes the sample size that might be required. So how often it's going to happen. But a lot of times we can't pull out the fact, but I use TPA as an example in stroke. I would love a treatment that was 1 to 2% better on absolute scale. Like if people are 40% disabled with TPA, it would be great to find something that could get them up to 42% disabled. The problem is that would require a 30,000 patient study, potentially, 15 to 30,000 patients. And we all know that that's the case. Everybody knows that that's the case. It's not that that effect size of 2% isn't meaningful. It is that the resources to precisely estimate that effect size are unlikely to be brought to bear. So it can be, and it's something that I do see, and because I work in the critical care space, like, and sometimes this comes up in the surgical space, like, well, surgeons won't change their practice unless you double survival or something, and that also seems like that's a little too draconian, right? Like, if this is a disease where there's 10% survival, increasing that to 13%, 14%, 15% would seem like a major win. That would be very, very game changing. So I think in terms of what is an effect size that's doable, it's hard, I think, because there's this idea of what's a scientifically important difference, but there's also the comes into play of how large a study would you have to find that. But you don't want to, but I think the thing that you don't want to do is the opposite end, where you get sad, right? There was a pediatric cardiac arrest study, which in the end showed that about 20% of the kids getting 48 hours of hypothermia had a good neuro outcome, and 12% of the kids who didn't had a good neuro outcome. But the study was expecting this difference to be more like 8% versus 16%, and because it had moved closer to the sort of middle of the binary area, it didn't have enough power. So it showed that it was a quote unquote neutral study. So that's the risk, is if you go for too high an effect size, you'll see something that you'll be really sad you didn't have more patients to truly confirm with more specificity. That was long-winded. Sorry.
Well, I mean, effect size is a difficult concept to talk about in early phase studies too, because there's an effect size that you would want to power your phase 3 trial to detect that's maybe a clinically meaningful effect. And I think you probably want to have that in mind as you're designing your phase 2. There are designs like the futility design, we didn't go into detail, that we mentioned, where you can assess in a phase 2 how likely are you to meet that criteria if you went to phase 3, and use that as your go, no-go criteria. To kind of elaborate a bit on what Will said, what you want to avoid doing is powering your study for an effect size based on how big of a study you can do, and not based on what is clinically important. So if a true effect size is 2 units on whatever scale you're looking at, and because you're doing a smaller phase 2 trial, you could have good power to show a difference of 4 units. That's probably not the best study to go forward with, because you're basically saying if my drug, my intervention, whatever works really, really well, I will find it. But if it doesn't, and it's still within a clinically meaningful scale, I'm not. And then, by your criteria, you'd have a negative phase 2 study when you probably have evidence of an intervention that might work, and then you're kind of boxed in with what you did. So you don't want to just choose an effect size to make your numbers look good, which is a trap I think a lot of people fall into, especially early in their careers when they're trying to just justify the sample size. You still want to keep in mind how that relates to the size of effect that you would ultimately want to show. Again, it's this broader thing of thinking of this as a program, right? Where are you trying to go if this is successful? What is the end game with respect to this line of research?
So there's 2 other questions that are worth, one is worth revisiting. Chris partially answered it, that came in earlier about how selective to be on a subject population in an early phase trial. Should you use less stringent inclusion-exclusion criteria to get better recruitment? And then the other question is about composite endpoints, and that have never been validated as a composite before. So I'll let you guys pick which one you want to answer first. Maybe the first one first.
I can take the last one real quick, because
Right,
I think whether it's composite or whatever, you should never be using an endpoint in a clinical trial that's not been validated. It's not going to be convincing. You're just basically making up an endpoint and putting all your hope in the trial results that it's right. And if it turns out that it's not a valid endpoint, you don't really know what you've shown. So I think whether it's a composite or not, you probably want to have some sense of the characteristics of the endpoint before you put all the time and resources of what it takes to do a clinical trial in the results of that endpoint.
Yeah, I think maybe if there was a little bit more detail about what was being compositized, so to speak, because I think one of the reasons oftentimes composites are used is because there's insufficient events with any single type of component of the composite, but that leads to problems in that, if you're saying, I'm going to do a composite of mortality and ankle sprains or something. I mean, that's a really dumb example, but that, but since it's a lot more likely to sprain your ankle than to die.
Well, it's not a bad example, because it gets to, you have to think about how you weight the different elements of the composite, right? And you probably put more weight on mortality than an ankle sprain. If you gave them both equal weight, it's probably not a good composite.
Right, exactly. So I think sometimes it may be driving a desire to get, and it may be driving a desire to see that you may think your treatment may have effects on multiple domains. And I think that probably a carefully selected secondary outcome, endpoint, if you're like saying, I think this is going to move the needle on stroke disability, but I want to have an important secondary endpoint on health-related quality of life, I probably wouldn't do something where I multiplied the modified Rankine by the stroke specific quality of life to create some new funky outcome measure that was a sort of a primary that compositized those 2 things, because I think that'd be hard for people to understand. There may be a good thing that could be done from that, but that would not be something that you would propose up front. You'd have to derive that from data from a variety of studies, and then try to test whether that works well in a future study.
One of the most famous examples, especially in the field of neurology, of a composite endpoint being successful, but also some of the caveats of composite, is the NINDS-TPA study. So that was a clinical trial that used a composite endpoint and met success on the composite endpoint. But in all honesty, the only reason that composite was as convincing as it was, because if you also looked at each individual component of the composite, you saw the same thing. If those individual components weren't consistent, even though the overall endpoint was significant, that would be a little harder to wrap your head around. So that's one of the challenges with composites too, is if you get significance on the composite, but not on the others, it changes the interpretation of what you're seeing and can complicate some things. But that's a famous NINDS trial that used a composite endpoint to success.
And I think, was there one other question?
The other question that I brought up was the one about selection, how selective
Okay, yeah.
I answered it, but kind
I-
of punted on it, so maybe
Yeah,
you guys have
yeah.
better thoughts. 'cause
I can riff off that a little bit. And if there aren't any other questions, then we'll probably bring things here, at least in the first phase, to the close. And then those folks who are interested in hearing about how things will progress for the 2022 cohort, then we'll pause the recording and then restart. I think it's tricky. I think if you are worried about, I think you should probably try to match your inclusion exclusion criteria as well as you possibly can to what you would be doing in the next phase trial. Sometimes you might learn about differences in who is available in your study that you didn't anticipate initially, and the distribution of some of the risk factors or phenotypes might be different. That being said, if you have a very targeted intervention, if you're targeting an estrogen receptor blocker, you definitely want to limit your study to people with estrogen receptors or tumors with estrogen receptors if you're thinking of like a breast cancer type example. So I think the thing where people sometimes get worried is that there's people on the boundaries of severity and prognosis. People who are so bad off that it's unlikely your treatment is going to be able to change their trajectory, or people who are so well off that it's unlikely, that people are going to do pretty well to begin with. Like they're not going to contribute to your estimation going forward of does your treatment work. Oh gosh, my computer is going to restart automatically. That's a problem. Anyway, it's like giving me the complete force of you need to leave. So we got a few minutes. So anyway, I would say that like, I don't know, Chris or Lori, do you have anything you want to add there on the balance between a big tent and a small tent, so to speak?
All I said in my response was it kind of depends on the disease and the situation. I think it's hard to give a single answer. I will say probably 75–80% of the trials I've worked on, the PI started off with a really narrow set of inclusion exclusion criteria and found out early on they can't recruit for the study and then broadened them. That's a pretty common thing to happen in trials.
Yeah, I would agree with you, Chris. I think you need to determine what is key. Here's a nice input from Santi, right? So in very early exploratory studies, to better understand selection of patients that might benefit from surgical or endovascular treatment, does it make sense to also try for efficacy and safety signals? Oh, I thought he was going to talk about something else. So he's asking a question. Sorry, Santi. He's asking about whether or not look at efficacy and safety signals for subsequent phase 2 studies as you move forward with.
You probably wouldn't be powered to do it, but you'd probably want to collect the data to see what.
Yeah, I would. That's what I would say. Is you still need to keep track of it, obviously, as you move forward.
I think the big trick in these things though is what is, particularly for stroke in terms of reperfusion, like what is the difference between safety and efficacy? If I give somebody pneumonia because they got aspirated because they were intubated for my endovascular procedure, but they walk out of the hospital, do I really care that they had pneumonia? And that in stroke, the functional outcome captures the sequelae of both the safety outcomes and the efficacy outcomes. So I think that's something when you look at class, and that's one of the things that I think is an important issue in terms of how we think about things in the course. If you look at, if you're thinking from the cancer paradigm of clinical trials, you can't shrink a tumor if the chemotherapy is intolerable because the person is completely sick, can't eat, can't drink, and so forth. Whereas giving a single treatment for an acute condition, the safety and the efficacy can often be rolled up into the same same outcome measure to a certain degree and same endpoint. So I think that's one of the things, like, because you know, so sometimes people see like a little blood, like there's a little hemorrhage, but the patient has a great outcome. So like, I mean, I think we matter more about how the patient feels, functions, and sort of lives, as opposed to what their head CT looks like. So I think that's a trick.
And they don't sprain their ankle, right? Well,
They sprain their ankle. All right.
Are
So
you
I
going
think
to log off?
well, we won't log off. So for those of you
You.
who are here for the 2022 cohort, we're going to have a brief kind of overview of just some of the things that are going on with the course. So I'm going to stop the recording here, and then we'll just restart it.